is Stemper. I'm talking about Bankart lesions. Like Dave said, it's just an avulsion of the labrum, usually on the inferior side of the inferior glenohumeral ligament. There are multiple classification systems, and all the articles I was reading, every author kind of just made their own up. There really wasn't any consistency throughout. Some of them included the joint capsule, some of them didn't, but typically it depends upon whether the labrum is taking a piece of the glenohumeral or glenoid rim with it and creating an avulsion fracture, and how big and displaced that fracture is. It was originally described by a British doctor back in 1938 in his observations throughout his surgeries. And signs and symptoms, it's very similar to anterior instability. You can possibly have crepitus if it's an older injury. They're going to have pain, and a lot of times they're just going to say they don't feel very stable, especially when we put them into the externally rotated position with abduction. It's almost always seen with an anterior dislocation. I never saw anywhere where it just happened on its own without the dislocation or subluxation. And it's also very commonly found with a Hill-Sachs lesion as well. Risk factors, it's overhead athletes where they're in an externally abducted rotated position. If they're obviously doing competitive sports, or if they have hyperlaxity in their anterior capsule, it's a risk factor for the anterior dislocation to cause that lesion. And it's also considered a predisposing factor to have recurrent dislocations anteriorly. And anybody who has a possible bone defect is at a greater risk for their surgical intervention to fail and go back to reoccurring anterior dislocations. And then treatment, there's multiple ways. You can try to conservatively treat it. If it happens, you can do rehab, strengthen the rotator cuff, try to put some kind of stabilizing brace on it to keep the humeral head in place and not allow it to translate anteriorly as much. Otherwise, you can do surgery to tighten the capsule, reattach that avulsion, and reattach the labrum to the glenoid rim. You can either do an open or you can do it arthroscopically, and the arthroscopic surgery has kind of become a little bit more common recently. And the most common type of repair is the Bankart. There's multiple methods of reattaching it, but that's the one that has shown in research not to change shoulder kinematics as much and to affect range of motion post-surgery. And they basically just either sew the labrum back together. If there's an avulsion, they put anchors in that are not biodegradable, but
absorbable.
There you go, thank you. And so they'll just absorb as the body heals, and then it just is supposed to heal back down. And all of those, either conservative or surgical treatment, you're going to go through periods of immobilization to let it heal, and then a lot of rehabilitation to regain range of motion and strength.